Hello, everyone, and welcome to today's webinar hosted by the Canadian Frailty Network, or CFN. My name is Perry Kim. I'm the Assistant Scientific Director at CFN. Today's talk is titled, Today's talk is titled Development and Feasibility Evaluation of a Web-Based Intervention for Frailty Carers of Persons with Dementia Residing in Long-Term Care. The speakers today are Wendy Duggleby and Laura Cottrell. Just before I go into formally presenting our two speakers, I just want to take care of some housekeeping issues. At the end of the presentation, there will be a Q&A session for about 10 to 15 minutes, depending on how long the talk goes. Please submit your questions online during the presentation, and you'll see on your right-hand side there's a window where you could type in the questions, and we'll answer as many questions as time permits. Just as a reminder, there will be a survey at the end of the webinar after you've closed up the webinar, so please do fill in that survey if you can. Just spend a few minutes. Tell us what is good about the webinar, what's not so good, and also if you could suggest future topics for our webinar series, that would be great. The webinar today will be available in video format within 1 or 2 days on CFN's website. Just as a reminder, this is a webinar series, and so we have a number of webinars scheduled, one on August the 29th, and that's with Michelle Gridman at the University of Calgary and Greta Cummings at the University of Alberta. And we also have a webinar scheduled for September 12th, Mixed Method Feasibility Study looking at ACP, and that's by Doris Barwich at the University of British Columbia. Lastly, just a reminder, if those that haven't done so already, just as a reminder, CFN's 2018 National Conference is scheduled for September 20th to 21st in Toronto. Please do register, and you can find the details again on our website at www.frailtyconference.ca. So without further ado, our presenters for today's webinar are Wendy Duggleby. She's a professor and endowed nursing research chair in aging and quality of life in the Faculty of Nursing at the University of Alberta. Her areas of interest are or include gero-oncology, psychosocial oncology, family caregivers, and palliative and end-of-life care. Laura Cottrell, who's also on this project, just recently received her PhD, in fact, yesterday. She's at the Faculty of Nursing at the University of Alberta, and her primary interests are in aging, palliative and end-of-life care, and qualitative methods. So without further ado, we'll switch the presenter to you, Wendy and Laura, and please take it away.
Hi, my name is Wendy Duggleby, and it's a pleasure for me to be here with Laura Cottrell to discuss with you some of our work we just most recently completed. And we are definitely looking forward to the questions. So we're hoping we'll get through this pretty quickly in about 35 to 40 minutes and give us some time to talk with you about, how we develop this and also our feasibility testing. But I just want to recognize first our many partners. There were some very helpful in this project, and I want to particularly thank the Canadian Frailty Network for the Catalyst grant funding.
Wendy? Hi, Wendy. Could you just go to this? Yeah, could you just go to the top left corner and hit display settings just to make it full screen? Yeah. And then, yeah, right there.
Oh, that's great. Is that, oh, thank you. Okay.
Much better.
Okay.
Thank you.
Thanks. Okay. So I want to, before we, these are the objectives of what we were doing, but I want to just take 2 minutes to talk to you about the difference between adapting an existing intervention and what we call about tailoring. They're not the same, and very often in the literature, they get used interchangeably. So just remember that adaptation is to make changes to the content of an intervention based on the core values of a group, while at the same time preserving the intervention's central tenets. And whereas individual tailoring means that you can accommodate within an intervention individuality, so people can, on a case-by-case basis. So what we have here is, we're going to talk a bit about how we adapted one intervention, but the final intervention, which is called My Tools for Caring Care, is actually also can be tailored. It's a very flexible intervention. So I just wanted to mention that so that you can use that as a backdrop as we move forward with our presentations. So that's why we wanted to understand, describe the process today, talk a bit about, because it was wonderful, the participation throughout this entire process of family carers in the development. And then we're going to end with, the findings of the feasibility study and some future directions. So again, thank you. What a wonderful team, research study team we had, and you can see from across Canada and our international partner from Queen's University in Belfast. Our knowledge users worked hand in hand with us through this process as well. Our advisory committee members, and thank you. And you can see Laura was a trainee, but also to our other research coordinators and research assistants. Our contributing partners, without them, we couldn't have done this work. So always very grateful for their support. I'll hand this over to Laura now.
Okay, thank you, Wendy. And hello, everyone. As Wendy said, I was a trainee. I was very fortunate to be a trainee on this project. So thank you to the Canadian Frailty Network for that opportunity. In this slide, this shows a picture of one of our participants, actually, with her mom. And I just wanted to talk for a minute about the body of literature about the quality of life with family caregivers of persons living with dementia. We know from the literature that there's a significant decrease in quality of life, of course, and particularly after family members are placed in 24-hour facilities. There's a lot of literature actually that shows that caregivers' mental health actually decreases after the placement of their family member with dementia. So the background to this My Tools for Care, based on transition theory, as I think Wendy said, we developed an online supportive intervention for carers of older persons with dementia living in the community. And it was evaluated, and quite recently the results were published, which showed positive outcomes for carers who use the tool. And this next slide just shows the front page to the toolkit. That this is where, when the carers log on to the system, this is where they first see, and they can sign into their own sort of individualized page. And again, this just shows from the website how to use My Tools for Care and shows some of the activities that people can look at. And you can see on the left bar there, it gives the sections in the toolkit.
Oh, sorry about that. Let me just, right here.
There we go. So the research questions for the phase 1 of this project were, we wanted to revise the My Tools for Care because we were approached by caregivers in the community who weren't, or sorry, by caregivers who had family members living in 24-hour facilities who weren't eligible for the My Tools for Care project. We were approached by those caregivers and who asked for a tool that they could use. So our questions were what revisions should be made to the My Tools for Care to adapt it to the needs of family caregivers of older persons living with dementia who reside in 24-hour care facilities. We also wanted to evaluate My Tools for In Care for ease of use, feasibility, acceptability, and satisfaction with the toolkit. Thank you. And here's just the inclusion criteria. Fairly straightforward, I think. The only unusual thing here is that they had to have access and be able to use a computer and have an email address, of course. And people were excluded if their family member living with dementia was not in a 24-hour care facility. Oops. So this slide just goes through the process of the phases of the project. It was a three-phase method, mixed method approach, sorry, with the qualitative and quantitative data collected from stakeholders and mostly from family caregivers. And I'm going to talk mostly about phase one, and then Wendy will talk about the other phases. So the phase one was the review of the My Tools for Care and recommended changes. We did 2 focus group interviews in 2016 with 9 family caregivers recruited through the Alzheimer's Society, and the purpose of those was to review the My Tools for Care and make suggested changes. And we also surveyed Covenant Health site administrators for their suggested changes to the online toolkit. But the thrust of our data collection was from the actual patient or the caregivers themselves. The objectives of the focus groups were to explore the post-placement transition process to inform revisions of the toolkit. And sorry, the question was, guiding this, was how do family caregivers of persons living with dementia describe the changes and difficulties they experienced after the family member was placed in a 24-hour care home? So the focus groups were held in the Alzheimer's Society of Alberta in Edmonton, and were about 1.5 to 2 hours in duration. Each focus group was facilitated by a trained research assistant and was audio taped, and the data were transcribed and checked for accuracy. The next slide gives you a little bit about our focus group participants. You can see most of them were female, and most were, 89% were a spouse of the care receiver. The range of time that care receivers lived in 24-hour care was 5 to 55 months, with a mean time of 24 months. So in the focus groups, we wanted to know about the biggest changes that participants had had once they had been, once their family member with dementia had been admitted to a 24-hour care home. And with transitions, we wanted to talk about how people adapted to the significant disruptions in their lives that were in part geographical, developmental, situational, and we really wanted, our objectives were to help with the adaptation process. So we wanted to look at what would help with these changes. And the focus group participants during the focus groups reviewed the My Tool for Care tool and made suggestions to the tool. The team wrote a paper on the focus group analysis, and we looked at, from an interpretive standpoint, did sort of a thematic analysis looking at the significant changes and the significant transitions that caregivers went through after their family member with dementia was placed, based on transition theory, which provided the theoretical scaffolding for the paper. And what we found from these participants was that there were 4 main themes, and the first one was living with loss, and this is not unusual in the dementia caregiver literature, of course, and this loss included loss of self, but it also included a loss of control when that person was placed in the facility as the healthcare system took over the care. Relinquishing was another theme, which included a physical and emotional separation of that person once they've gone into the caregiving facility. Participants described having to redefine their caregiving role. In the past, when their person was at home, they had worked mostly on instrumental tasks, and now they had to learn new tasks in relationship building, communication, advocacy, and other navigation skills. And as this transition progressed, they became to a phase where they were able to rediscover and recreate a new self and learn to forefront their own needs in their lives and to learn to live a new life. And so this just shows, Wendy will explain in a moment the overall model, but this shows you, or the transition framework, sorry, this just shows you where in part this fits into the transition segment of the framework. So
Thanks, Laura.
thank you.
So the reason why we're showing you these slides is we follow very much the UK Medical Research Council guidelines for development of interventions, and they talk very much about needing that conceptual foundation to guide the development of your intervention. So we had, through several studies, developed this framework for My Tools for Care. But remember, we were now adapting that. So we integrated what Laura talked about, and this is then became our frame for adapted framework for My Tools for Care in Care. So that you can see in green some of the pieces that we added that were different from the other framework. So this was extremely helpful as we move forward in our work. So what did we do? So, and I know it can be confusing because the names are so similar. Remember, My Tools for Care was for people in the community, but My Tools for Care in Care is the one for that we developed and adapted for persons, family carers of persons living with dementia in 24-hour care. So what was new? We have several activities that are interactive, and what people go on is log in and they can download and they can add pictures. Anyhow, this one, it's a section about me, and what we added based on what the focus group people told us is how can I manage the guilt I feel, the importance of working together. So that's working together now at this point with staff, at how to advocate for care. And of course, what was really clear is we needed to have some important activities to start the discussions for goals of care at the end of life. There's a section called Common Changes to Expect, and we revised it. That all it is, it's not interactive. It just gives examples from what other carers have said about what happened to them, what was happening to them, and so that was what we did here. We have a section on frequently asked questions, and again, we changed that based on what the focus groups told us. So just in comparison, of course, and then we ended up developing a whole bunch of new resources based on what they were told. So that was, and each one of them, we are all evidence-based. So we did significant literature reviews to get to this piece, these resources. And we removed some things, right? So they said that we want these things, but we don't want those things, which was very helpful. So phase 2, we then worked with our web development partners, Atmist, and we developed My Tools for Care in Care. We did field testing. Again, we had carers help us, so that was really important. And this is what we ended up, this is what it looks like. So this is the front page, and it can be used on people's smartphones, on their iPads, as well on computers. So again, they sign in. There's instructions on how to use it. Again, it's very flexible. The section's on the left-hand side. And I'm just going to, I hate this when the other presenters do it, but I'm going to do it to you. I'm going to run through some of the pieces, and if you want to see them again, just let me know. The About Me section is the interactive one, and some of the activities they could do was where I am. Remember, this is all about, this is specifically designed and focused on the family carers themselves. Family being very broad, including friends as well. What helps them? What are their goals? Yeah. How to work on hope every day, what to do, some self-care for themselves, how to manage this guilt that they have, how to work with other staff, how to advocate for care. for their family member, how to start thinking about goals for care at the end of life. And again, common changes, frequently asked questions. That's just an example of the facts to be developed. And then we did the feasibility study. So I'm just going to run through very briefly. We collected data at baseline 1 month and 2 months of 37 participants. And you can see we used the SF-12, the General Self-Efficacy Scale, Health Hope Index, the non-death revised grief inventory, and we actually took a look at some costing with the health service, social services utilization inventory. Just briefly, some of the demographics of the family carers there. Now, we had them keep track of the minutes they spent on different activities, and interesting enough, at 2 months, the Everyday Hope activities, the one what they spent, a meeting of 30 minutes. So it's the one they spent the most time on at 2 months. Ease of use, we have a measurement. This is where they talk about whether they agree or strongly agree or too strongly disagree. So it's the opposite way around. Strongly disagree to strongly agree, so the higher the scores, the more agreement. And you can see here at 1 and 2 months that the ease of use was quite good. The directions were clear, with 90% here. Online format is easy to use. In terms of feasibility, they certainly found the online format convenient. Acceptability, so you can see here at 1 month and 2 months, they actually felt it increased their ability to deal with significant changes. And, you know, at 1 month and 2 months, these scores are 93, 92%. So almost 100% of the participants said they would recommend it to somebody else. So in terms of the Health Hope Index score, we found that there were significant increases in the total Health Hope Index scores, and specifically, this breaks down to 2 factors in factor 2 and factor 3 compared to baseline. This is the grief, so you really want this to go down, and it did. We had significant decreases from baseline in grief scores, in particular existential concerns, depression, tension and guilt, and physical distress. So it really appears, even though you know, there's no comparison group, it really appears that there's some potential here for this tool to have a positive impact on family carers. We still didn't see any changes, but we didn't expect to see any changes in the SF-12 because of the very small sample size. But interesting enough, you know, with the hope and the loss of grief, they actually were significant related to, in this feasibility study, physical and mental health. So it appears to be easy to use and acceptable and has potential. And I know that was quite a whirlwind, but anyhow, some of the next steps, of course, we're thinking about this was a Catalyst grant, and certainly we did the feasibility study. But some of the next steps, of course, are to do further evaluation with it. There was some recommendations from the participants, because remember, it was a mixed method study. So we have qualitative interview data that supported all the quantitative findings in terms of ease of use, feasibility, acceptability, and hope, and the decreases in grief scores. But they also had some recommendations, and they were interesting. They wanted more pictures. I mean, they liked the pictures that were there, and wanted more pictures. And so they're not difficult now for us to revise and move forward to a larger study. So we took about 30 minutes, and so that's great. I'll leave the floor open for some questions now and some discussion. And please feel free to contact us afterwards.
Hi, Wendy. Thanks a lot, and thank you, Laura, for the talk. Just want to remind everyone that you could type in your questions on the side panel. As I wait for questions to come in, Wendy and Laura, can you, I'm not familiar with the UK MRC transition framework, and I noticed you had it up there. Is it possible to sort of briefly go through that framework and why it's necessary?
Okay, so just to clarify a couple things. We talked about actually transition theory that was foundational to this work, and that is Malice. Malice's particular work. There's other transition theorists. The difference between what we often think about in terms of transition of care versus the type of transition Malice and other theorists are talking about is the transitions. A transition of care can trigger these significant changes, right? And for family carers, the significant changes are changes in relationships, and you can tell from some of Laura's data that there were some personal losses. They had to redefine. They had to learn to work in a new environment. They had to really find a new life for themselves. So they were going through life-altering transitions. Why it was important to us, because we looked at and had done and read several of the systematic reviews on other web-based interventions. We couldn't find any, and we looked again at anything that was specific to family carers in long-term care, persons with dementia long-term care. But there's many, well, I don't want to use the word many. There was about 12 studies, other web-based interventions for family care of persons living with dementia in the community. But when we took a look at them, there was some very mixed results, and a lot of them are based on their theoretical foundation for the interventions are on caregiver burden and stress. And they very few actually, without a doubt, they just didn't seem to be positive outcomes. And because our outcomes were quality of life, we felt that the transition theory was a better foundation from which to develop the intervention. Now, what I mentioned, though, and I'm happy to send this reference, but the UK Medical Research Council have guidelines on how to develop complex interventions. And that guideline takes you through several stages on how to develop interventions and evaluate them. And it starts, number one, with remembering that interventions need to be based on a conceptual and theoretical foundation. Because how else can you choices make decisions about what's going to be in your intervention? And how can it be? The whole idea is that the framework will help you make, and for us, it wasn't just the framework, it was the family carers and the research team and our advisor committee that really, really helped decide what are the most efficacious pieces that can be in an intervention that's not going to kill everybody, that's simple and easy to use, because you want people to use it, right? So, so that's why in this presentation, we, took you through those beginning steps, because it's so important that what we were going to do had a strong conceptual foundation to guide, to adapt, to make it representative and something that's feasible and useful to these family carers. We wanted it to be effective. And so that's the first step in the UK guideline. And they say you can come to that through different ways. I mean, you can find something, possibly the literature. We did look in the literature, but felt that we needed to have more information, and very often a qualitative study is one of the best ways to get at that. And then the next steps include to make sure we do feasibility testing. Very often, and there's discussion literature between a feasibility study versus a pilot study. But whatever route you go, it's just really important to make sure that for your targeted population, it's both feasible, easy to use, and acceptable. And without that, there's no reason to go further.
Right.
You need to go back to the drawing board, right? So then they move from there to the normal steps. They talk about, we think about the different clinical trials there are, phase 2 and phase 3 clinical trials. So it's really a very useful guideline I found with all the interventions we've developed about how to go step by step, and not everything always works out, right? So we were really pleased with this one. But I think it's for anybody that is looking at developing interventions, and they use the term complex interventions, but our populations are so complex that no matter what we do, I think will always be a complex intervention, particularly if you want it to be a flexible intervention. It just adds a whole bunch of complexity to it. Was that helpful?
Yes, absolutely. Thank you very much for that, Wendy. And we've got a number of questions now coming in. I'm going to try to sort of summarize a couple of questions that are sort of related, and that's with respect to future versions, if you will, of My Tools for Care, in Care, as well as My Tools for Care, in terms of different ways of conveying information. You mentioned pictures might be better. Some people suggested maybe some videos as well as whether there's any plans to make it more broad in terms of different languages and addressing different cultures or different vulnerable populations like the LGBT community and so forth. If we could hear your thoughts on that, that'd be great.
Oh, thank you so much for that question. A very interesting, because I met this morning on my way to work one of my team members, and that's Dr. Jane Triscott. And she her work is she's a physician that runs a care of the elderly clinic for actual persons with dementia at the Glenrose here. And her work has very much been with Indigenous populations and taking a look at other culture groups. And she said, Wendy, there's definitely a need to take this work. And I think what I would recommend is, because you probably saw that in our demographics, and so that's definitely a limitation, is who our demographics were even in this feasibility study, is the need to broaden it to be more diverse. Think about diverse populations. But I truly believe, because, and I'll give you maybe another reference if people want to look at. It's by Collado, and it's called Cultural Adaptation and Individual Tailoring, 2 approaches to the development of culturally responsive treatment. Now they're talking about treatment, and this was published in 2013 in Primary Care Companion. But it's really good because it talks about, again, if we're now thinking about culturally adapting things, that we really need to do something very much like we did with focus groups, to take a look at an intervention and to really involve individuals from those different groups first to adapt to it. I think there's 2 aspects to this intervention. And that's, one is the content. And remember, we use transition theory and then our other work and then the focus groups to get at what was key content, right? So there's that adaptation, but there's the delivery mechanism. And of course, our delivery mechanism is a web-based intervention. So there's two parts to this piece, right? That we need to really think about in terms of adaptation and as we diversify. I think and so I really appreciated that because even with language, we've been approached by a francophone community here in Alberta to do that. But language is far more than translation, right? Language is culturally embedded. So again, my response to them, oh yes, we should really do this, but let's remember that I think we need this, need very much this approach. I think one of the reasons, and I think videos was something that is really important. We have one video in there, and that's the Living with Hope video, and I think that's why people were spending more time on that, but then we ended up with some great significant changes in their home. The videos I've done, how many videos have I made? Made about 5 videos now based on research studies, and we use a concept called video modeling. And what video modeling incorporates is that you want people, when they watch the video, so whoever's watching the video, you want them to be able to identify and see themselves in it. And that's when we get changes in behavior. So so the videos, the Living with Hope video it's the Open Connection one. Each of the videos we've done, what we've done is you will see actual people. So the Connecting with Hope video that's on My Tools for Care in Care, they actually see other family carers of people living with dementia in 24-hour / long-term care. And they're talking about what happens to their hope and how they keep hope and how they, and a lot of the scenes are actually within a facility, and so you'll see them actually interacting with their family member. So I think that's definitely a really important piece, and as we think about diversifying My Tools for Care in Care, we need to really be thinking about our pictures, and we need to be thinking about the language we use, and we need to really be thinking about videos, because there's a lot of videos out there, but it's whether it is conveying the message that will be have an impact as well.
Great, thank you, Wendy. I really appreciate the fact that it's not just a straightforward, English translation to other languages. I appreciate that there's a lot more to it, which I hadn't really considered. We've got a number of other questions up. I'm just curious, and I would encourage all listeners to actually visit your academic website, because I did visit just recently and saw some excellent videos on some of your other research projects like N-Care as well, and they're really well done. Just a brief question on, so you had made changes from My Tools for Care to My Tools for In Care, and one of the things that I guess the focus group suggested that you maybe drop or eliminate was the question or aspects of advanced care planning. And I'm curious if that was something that surprised you, or was that because when I saw that, it surprised me that ACP wasn't something that one should maybe put in your new tool. Is that maybe because they're familiar with your My Tools for Care tool, and so they've already gone through that step?
Well, thank you for that. I appreciate that, because actually what they wanted new was the goals for care at the end of life that's more interactive. So when they asked us to take out that plan A had, the legal and financial issues and the advanced care planning piece, what's in My Tools for Care isn't interactive. It was a document actually that, and the same with the legal and financial issues. So they wanted something more interactive. So what we ended up putting in is a lovely tool. What it is so the actual activity, right, is to start talking about this. What is it that you as a care, what is your goal as a carer, but also start talking with family members about what would be important, what kind of care is needed at the end of life. And then we still have huge long list of resources, because the resources are really important. But we added a new one from Dr. Genevieve Thompson that actually is, she's developed this and evaluated it. It's a list of questions that family caregivers of persons in long-term care can start to engage with staff about. And so it was more the format of what we had in My Tools for Care. And they wanted more. So they wanted a place where they could put their thoughts and their feelings and what they were thinking about, as well as resources. So it wasn't the concept and the fact that they didn't want to do it, but what they wanted to do, they wanted more. And they said it would be more helpful if they had something that they could start interacting with staff about. So, and I should have made that clearer. So thank you for picking up on that and asking. Does that make sense?
Yeah, that absolutely does, and it's great that it's more thorough, I guess, lack of a better phrase. And thank you for that.
Yeah, and more interactive, right? So that they could jot things down instead of just getting a pamphlet, right? Online. So they put things in online, very private, yeah.
Excellent. I have a number of questions, but again, I'm going to try to sort of summarize a few different questions related to whether the tool can be sort of used for clients that perhaps don't have dementia but are still in a long-term care facility. Would it be appropriate for others to use that tool? Because the tool right now seems to be specific for patients living with dementia.
Yeah, one of the hardest decisions when we started this, and we had lots of discussions with our advisory group and with our research team. I mean, there's still, it's still at least 40% or maybe more, in our facilities that don't have dementia. And what can we do for them? And so it is one of the plans, and I don't think it wouldn't take much, but I still think it would take just a moment to have a group look at it to make it broader. And then what we could do is then it could be used for everybody. And then what we could do is maybe have a subsection that was, if you did have someone with dementia. Some of the pieces we ended up developing, based on Laura's work with the focus groups, is one of the tips about how to communicate with their family member with dementia. So you'll see that within this because we did make it specific for them. And so some of those things in our the activity is kind of you know, we've developed this based on evidence, but, you know, maybe try something and see if it works and jot it down, because everybody's so different, right? But I think that's a long way of me saying this one was specifically developed, and I think we would need to do just a little bit more work to broaden it. But it was a hard choice. It was a hard choice to decide on that. But because My Tools for Care was built on for persons with dementia, was kind of the first step in adapting it. So thank you for that suggestion and idea, Jude.
Great, thank you. And fair enough, you do have to start somewhere, and certainly that's a great place to start. I have a number of questions with respect to the tool and the availability of the tool, whether it's accessible across Canada and so forth. And I think the answer is yes, and it is free. Anything to add there, Wendy? And where can they go to actually find the website? Should they go to your academic website and then go from there, or is it just a quick Google search for the tool?
Yeah, so here's the piece around that. They could go ahead and access it. We've been working with the Alzheimer's Society here, and it is available on their Asant Cafe. So www.sant.cafe.ca. Sorry. So it is available there under their educational piece, and anybody can go there. Both My Tools for Care and My Tools for Care in Care are both on that website. That was purposeful to make it sustainable. So, you know, that's probably the best place to access it. If you Google My Tools for Care, you can access that one, and it's free and open to the public by Googling My Tools for Care. If you Google My Tools for Care in Care, you'll get a URL, but that's not available to the public, and we just haven't made the switch over. But if you go to Asant Cafe, both of them are available there. And what's lovely about the Asant Cafe, it adds because they have a chat room, so it adds that's monitored on their site, on the Asant Cafe, and many other resources. So it's a lovely addition. If then on top, people also want to talk with other family carers.
Interesting that you mentioned the chat room on Asant Cafe, Wendy, because I do have a question here about whether there's any plans to incorporate a sort of a social component within My Tools for Care. So caregivers or people could sort of help each other out when accessing the tool. Is that something that you have possibly planned in the future, or is that something that's beyond the scope of the project?
Yeah, here's the thing about that. That's why we paired with the Alzheimer's Society. The plan was always that it would be sustainable and move to the Asant Cafe, because they have a chat room. The piece about chat rooms, they allow you to help connect carers, but it has to be monitored. It has to be monitored. So, the more you read about, so we made it My Tools for Care in Care is interactive, because they could put their own things up, but it's private, right? And it's only them, nobody sees it, and they can download and share if they wish. But the thing about chat rooms then is there's a piece that I think it is good, and it helps with social interaction, but only if it's monitored. Because there's been some instances where, and you can appreciate this, right? Anybody can go in a chat room, and so it has to be. And the Alzheimer's Society of Alberta Northwest Territories do monitor that, and they have social workers available if someone is in need. And yeah, so to me it was a better model, so we developed this framework without the chat room, and then to have it sustainable in a place where it could continue to be monitored.
Right. Yeah. No. We certainly have the same feelings with respect to some of the things that we do on our website as well.
Yeah.
It requires monitoring. Wendy, I have a few methodological questions. Questions like how was the sample size of the feasibility study decided upon, as well as choosing the focus group methodology versus other methods. Can you provide any insights on that?
Yes. So we just went to a very standard reference that talked about feasibility study, because we weren't looking to do at this point a power analysis, and actually we were hoping for 40. We got 37, but it was just a very tight time frame. So it's just a very standard. What do you need to have in terms of a feasibility study? Because it's just at the beginning. Remember, it's to be evaluated further, and then you go to the next steps where you would really look at a power analysis and what would be the piece. And actually we've submitted the manuscript, so it's got these all the references and stuff in there. So hopefully that will be something that a little bit later when it's published I can share. Now, the focus groups. So one of the reasons why we chose focus groups was that it was, there's a lot of discussion about focus groups, right? Whether individual interviews are better, or whether focus groups are better for this type of research. But we actually appreciated the group interaction that occurred, because it helped people think of things. So remember, there was two parts to it, and it was to get preliminary data on the kind of transitions they were experiencing, but it was to have them together as a group brainstorm about what they'd like changed to White Hills for Care that would fit their needs more. And so, it was a deliberate choice. And certainly we know with focus groups originated with market research. And so in a lot of ways, because we were looking also to have it theoretically sound, we also wanted it to be something that was acceptable. So, the look of it and the words that were used. So, it was a deliberate choice based on that background. And I certainly found, when looking at the data from the focus groups, it certainly did. It certainly was a very useful piece. Now, if in other studies, and as we developed other interventions that we weren't adapting an intervention from, we did do in-depth individual qualitative study first, followed by, we used Delphi methods with expert panels. And so there's different ways, I think, depending on at what stage your intervention is at. Is it something that's brand new? And so, I think it's a great question, because you just need to be really careful about where you're at. Do you need to, for example, we had transition theory in our other work. Do you need to, when you look at the literature, is there nothing that really seems to resonate with the population you want? In those cases, I've done a full-scale qualitative study to look at, to give a foundation to really develop the innovation from. So it could be either way, but from where we were at, this seemed to be the best way.
Right. Well, thank you, Wendy. We are getting to the top of the hour, and I think we could go longer with all the questions that we've got still, but I think we do have to close up this session. Wendy, we always give our speakers the last opportunity to sort of final thoughts or that sort of thing. Anything you'd like to add before we close today's webinar?
Oh, I just want to say thank you. I really enjoyed the questions and the discussions, and in a lot of ways you've re-energized me a bit to keep working and to start thinking about diverse populations, and to really be thinking about you know, how we might move forward. So I thank you for those questions, and I thank you for the discussion. And I also want to say I have to really thank again our family carers that participated with us through the entire process. Through the entire process, and the Canadian Frailty Network. You guys really encouraged that and emphasized that from the very beginning. And we wouldn't even have done this if we, as Laura mentioned, if they hadn't approached us and said, we need this. So how different it is, and how, I don't know, how exciting it is to do research when you have that kind of engagement. Anything, Laura?
Nothing for me, again, other than basically to echo what Wendy said, and thank you for the opportunity to the Canadian Frailty Network, because it was a real privilege to be able to work on this project. I learned a great deal and really gained a lot of respect for family caregivers, you know, patients with dementia.
Yeah. All right, thank you.
Well, thanks to both of you as well, and we would love to hear from our researchers, so thanks for taking the time for this webinar today. And thank you for all our attendees for listening on today's webinar. Just a reminder, our next webinar is August 29th, so please do register. And again, thank you, Wendy and Laura. And with that, we'll sign off. Thank you.